So we're going to start with our review of our bony landmarks of our scapula. So in our musculoskeletal book, we're on page 7, just to remind you. Number 1 is the vertebral border of the scapula. So we used to know the vertebral border from our cert class as a medial border. So on Elijah, if I come to the side, and don't be afraid to palpate. This is how we get more confident with our body work. So find that vertebral border of the scapula. Number 2, the axillary border of the scapula, which was what we used to know as the lateral border of the scapula. Remember, the lateral border of the scapula goes up higher than you think. A lot of people think it ends where the armpit crease starts. If you follow the bone, you'll find that it goes way up higher on the body. Vertebral border, axillary border. Number 3 is our acromion. Following the axillary border to the very, very top, what we used to think of as the shoulder bone is actually the acromion, the rounded part that goes around to the anterior side. Number 4, the coracoid process. The coracoid process is going to be on the anterior side of the scapula, the part of the scapula that sticks out in the front, and we will address that when we go to pectoralis minor. Number 5 and 6, the inferior and superior angle. If we follow both of the borders of the scapula down to the very bottom point, remember we kind of called this our little scapula island. The very bottom part of our island is the inferior angle of the scapula, and then the very top of our island is the superior angle of the scapula, which is a little harder to access because we have muscles that go over it. What we usually feel like is the very top of the scapula is our spine of scapula, which is number 10. I know I skipped number 9, I'm going to go back to it. Number 10 is our spine of scapula. We all know that from our cert class. And number 11, if I go all the way to the medial side of my spine of the scapula near the vertebral border, it's the root of the spine of the scapula. Going back to number 7, the glenoid cavity or the glenoid fossa. That is not something we can palpate. That is the socket of the ball and the socket joint of the scapula. So the glenoid fossa, the glenoid cavity, same. And then number 12, 13, and 14, all of our fossas. So the first one is our infraspinous fossa. If I go back to the spine of the scapula, infraspinous, inferior to the spine of the scapula, rolling off, everything underneath the spine of the scapula is the infraspinous fossa. Supraspinous fossa. If I come back to the spine of the scapula and I roll up to the superior side, I am now in the little divot of the supraspinous fossa. And then our last one, subscapular fossa, number 14. The subscapular fossa is the anterior side of the fossa, so to be able to show you, I'd have to cut through Elijah's scapula and flip it over to show it to you. We'll address it when we hit the subscapularis. And that is the bony landmarks of the scapula. So, moving on to our procedures. Number 1, the first thing we did is the fascia manipulation. So remember, this is kind of just the warm-up to get into the deeper muscles, and we're trying to kind of get through that superficial fascia to get down into the deeper fascia underneath. So using a grabbing, palming, pushing, pulling manipulation, what we're trying to do is just make contact with the fascia. So remember, we can just sink down to where we feel the muscle that we're used to feeling, and if we just come up just slightly, it takes us to the layer above that muscle, to that superficial fascia. Gonna get ourselves in a bow stance, tuck our trunk, get all of our weight into the back foot. My palm, this is gonna be my working surface. I'm gonna work with the top of the palm as well as the bottom of the palm. I think we just talked about this as the mama and the papa bear. We don't want to get too palmy because then we will not have a soft wrist. So we have to make sure the top of our palm is also engaged. So take a breath in, sink, feel that muscle that you're used to feeling, and maybe make just a little bit of a curvature of your hand to come up a layer, and then you're just going to begin to shift your weight forward just till you feel resistance. And then as soon as you feel the resistance, lean into it slightly with your weight shift from the back foot to the front, and let that fascia slowly pull you down. Since this is superficial manipulation, if you can go deeper, go deeper. Sometimes you find that people's superficial fascia is too gunked up to get into the layers below. But if you are focusing on the superficial fascia and you're just kind of warming things up like we are, this is considered that loose areolar connective tissue. So there is no direction that we are restricted to. So we can go in any direction we prefer. You don't necessarily have to follow, in this instance, a specific muscle pattern, even though later on when we get into specific muscle patterns, you might want to work on that superficial fascia along that specific muscle pattern. So I'm just shifting my weight from my back foot to my front foot, keeping my shoulders relaxed, my trunk tucked. And soon as I have all of my weight pressed into the front foot and I'm no longer using my back foot, I can just get out on my foot forward a little bit, shift the weight into it, take a slight step, and continue my stroke, especially if I have a long back like Elijah does. So a lot of the time, the one Tai Chi principle that I think gets forgotten is extended head, because we're always looking at our work. So often you'll see me just kind of close my eyes and lift my head up to extend my head, but also to help me see a little bit better with my hand. And I'm just feeling that fascia melt underneath my palm. And I'm going to go down until I hit his sacrum, hit the bone. And I'm working superficially, so I can go, the fascia is what connects the skin to the lining structures underneath, so I can go over the bone if I wanted to. So as I come down to his sacrum, another way to do it is to kind of cup your fingers and then pull your palm up to your fingers to go up the hill of the sacrum. That's one way to finish the stroke up over the sacrum. Another way to finish the stroke up over the sacrum is when I get to the bottom of the sacrum, just come back to where I already worked and have a loose fist and move up the sacrum in that kind of a fashion. So I may need to sink again. Relax my shoulders, extend my head, get my weight back into my back foot, and let my weight shift until I feel resistance, and lean into the resistance and let it soften to me. And this is another way to finish out that long stroke. But that being said, again, I can go in any direction that I like. If you find yourself not being able to glide, recheck your Tai Chi stance, get your weight back into your back foot, and begin to slowly shift your weight into your front foot. There we go, right over the scapula. So that's just a quick review of the fascial sculpting that we did in the very beginning, and that helps to warm the body up for the next procedure, number 2, which is our skin rolling. So the skin rolling, if I can refer back to Cirque, the fascia manipulation is a little bit like the effleurage would be, and the skin rolling is a little bit like the fanning would be, in the sense of the broadness of the stroke and the depth of the pressure versus with an effleurage and a fan. So the skin rolling, number 2. We're going to slowly roll superficial fascia between the thumb and the fingers, and the intention again is to break up and release the skin, the superficial fascia, from the underlying structures. So I just let my hands fall. They fall kind of into a triangle, and then as I shift my weight from my front foot to my back foot, I pull the skin into my thumbs, just like so. But I want my thumbs to be straight. So when I start, my thumbs are not straight. So when I pull the skin back, I gotta make sure that I have straight thumbs. We want a nice continual line from the radius to the thumbs. So shift the weight back, create that wave of skin, straighten out your thumbs, and then slowly, there's like a wave of skin going over my thumbs. So at the bottom of the wave is where my thumbs are at, and I want to slowly shift my weight into the base of that wave until I feel resistance, and lean into that resistance. If we go too fast, it's gonna feel very burny. So I just lean into that resistance until it gives to me, and I slowly work through the wave. I wanna continue the wave over my thumbs, so when the wave gets smaller, I gather more skin, shift my weight back, and continue the wave going down. Elijah, does this feel burny or uncomfortable in any way? Okay, if it ever does, let me know. Since I'm working superficial fascia, again, loose areolar connective tissue, I can go any direction I like. So if I want to turn and go over the vertebrae, it's going to get a little tighter, but I can do so. Usually I go into the area of least resistance, so if I find a spot that just is really stuck, it doesn't mean don't do it because it needs you there, but it might tell you go into another area in a different direction, loosen it up a little bit, and then that stuck area of resistance will be softer for you to work when you go back around. I hope you noticed whichever direction you do go, you stay behind your work, and I move my body to constantly be behind my work, and I'm constantly in a bow stance, shifting my weight from the back foot to the front foot. If I wanted to, which I'm going to go to with my first procedure is the upper trapezius, a way I might warm that up is I can start skin rolling this upper trapezius. I just got to get low enough to get underneath it. This usually feels pretty good. Correct me if I'm wrong. I got it, so we're doing all right. So it's a slow wave. When done correctly, this can feel very, very nice. When done incorrectly, it can feel very pinchy. One thing that I find myself sometimes doing is holding too tight. So we want this to be a loose grip with the shifting of weight into my thumbs. It's kind of like a conveyor belt. The skin's getting pulled up over the wave, from the front of the wave into my thumbs. But I believe you guys have also done skin rolling in sports. So this is just another opportunity to get better at your skin rolling skills. I'll just finish this line and then we'll move on to procedure number 3, the upper trapezius. You can see he's turning a little red. You can kind of see he's got his tan going on a little bit, but he's turning a little red, which is nothing to be, some people get a little nervous about that. This is just blood getting into the area. This is the body responding to the things we're doing. This is good. I like this. I don't mind seeing that at all. Okay, procedure number 3, the upper trapezius. So the upper trapezius is this big chunky piece of meat at the top of our shoulders where we kind of hold all of our stress. The insertion is the medial clavicle, the acromion, and the spinous scapula. Medial clavicle, acromion, spinous scapula. So if we go all the way up, its actual origin is the external occipital protuberance, one of its origins. So this hand motion here is the area we're going to be working. So the procedure, stroke or compress the upper trapezius with knuckles from neck to the acromioclavicular joint. So I'm going to start at the base of where the neck gets shoved into the body, that little cul-de-sac, and I'm going to come all the way out to that bony landmark of that acromioclavicular joint. And I'm going to use my knuckles. When I say my knuckles, I don't mean this, I mean in between, the space in between my knuckles. And I'm going to have not a tight fist, but a loose fist. So one of the things we want to do before we start there, it's a little harder area to get to, superficial sculpt it. Warm it up, get it ready for the more specific work. We already skin rolled it a little bit. And give yourself some space to work. Sometimes what I'll do is I will pull their arm down a little bit to open up this area to give myself a little bit more space to work. So, coming at the base of the neck, loose fist. I'm in a bow stance. I'm using the opposite arm of the side that I'm working. You can get right up against their head. They usually don't feel that. Remember with this stroke, it's very important that you find an anchoring spot near your hip area to get your pressure. Because if I don't use my body, it's very easy to use my shoulder for the pressure, and that's not good. That will hurt you very quickly. So, get your spot. You can kind of get under the trapezius. The trapezius kind of falls anterior a little bit when people lay in this position. So I kind of scoop it up to get it more accessible to me. I bend to get into a nice low stance. My spot is right on the side of my as is. And then I'm going to go for pressure first. So as he takes a breath, I'm just going to shift my weight forward. So it's coming up my leg, into my elbow, into my arm, into my loose fist. There's my pressure. My vector is going this way. But I have to get my stroke to go out laterally because my intention is to make space between the cervical vertebrae and the scapula. So now that I got pressure, I'm just going to rotate on my front foot, bringing my weight back into my back foot. Dantian is facing the direction I'm going to work, and I start shifting my weight into the front foot, waiting for resistance. And when I find that resistance, I just lean into it softly to encourage that fascia to melt, and then we begin movement. So I'm just going to slide out, take a breath, because I'm talking and I'm losing my breath. Slide out along the muscle until we run into the acromion. If you find the correct term was in adhesions, we use the word a dedunk. If you find a dedunk along the way, you can stop and go into a compression into that dedunk, or you can just finish the stroke out and then go back to that spot. Basically what we're doing with deep tissue is just following muscles along the direction in which they run and finding any abnormalities, and that abnormality is tight fascia, and we're just going to melt that tight fascia. As soon as I hit that acromion, you're going to slowly come off and then come on out. And I usually like to check my work, and usually if I look down the side that I've worked, I can see the space that I've made, especially near this little cul-de-sac where the neck meets the body, to see if there's more space, and I've opened up this upper part of the trapezius. I can also do a compression. So to do a compression on the upper trapezius, I'm going to come down and I'm going to be in like a pseudo bow stance. I believe it's warrior in our Thai massage. And I'm going to, when we say a elbow compression, it's more of a forearm compression. So here's my elbow, and this little ridge is the area that I'm going to use as my tool. So you can find your area that might need a little bit more attention, and this is going to feel like more pressure because it's a smaller tool than my broad knuckles. So find your space, and it's okay. Don't be afraid to palpate around to find where you need to work. And then you're just going to slowly, when you find your spot, with your breath, lean in. I like to take 3 breaths to slowly be invited into the muscle. So it just slowly softens and makes a little pocket. And I'm going for pressure first. I'm just going straight in. And now I've got my pressure, it's kind of creating a little pocket around my forearm. But now I need to get a vector, because our intention again is to make space between the cervical vertebrae and the scapula. So my vector is going to go along the line of that muscle. So I just have to tweak a little bit, and you can see his arm come down just slightly as I get that vector. How's the pressure? So if you wanted to be specific about the pressure, you can remember our number system, 1 through 10. 7 being hurts so good. It hurts, but for a purpose, but not to the hurt where I have to hold my breath or tense up. It's a hurt so good where I can still breathe into it. We never want to pass a 7. So you can always ask on the number scale where you should be. And once I've felt some change, some softening of that adhesion, I can just slowly back out, just as slow as I went in. So I like to take, usually takes me 2 or 3 breaths to slowly come on out. And that's just a reminder of the compression for the upper trapezius. Moving on to number 4, supraspinatus. So remember, the supraspinatus lays within the supraspinous fossa. So I need to find that spinous scapula and roll anterior to it. And it goes underneath the origin of supraspinatus is the supraspinous fascia, and the insertion is the greater tubercle of the humerus. So it dips underneath that acromion and it goes to the greater tubercle of the humerus. And that acromion is kind of like a little cul-de-sac that I have to slide underneath the spinous scapula to get under to that acromion. So since I'm working in a smaller area, instead of a broad, I'm still going to use a fist, but instead of a loose fist, I'm going to use more of these 2 parts of my knuckles instead of the whole part of my knuckle. So stroke or compress the muscle within the supraspinous fossa to the acromioclavicular joint. Same stance as the upper trapezius stance, but now just focusing in with the spinous scapula just above my top finger, finding my anchoring spot. Another point, levator scapula comes off laterally down, or it comes off into the superior angle of scapula. So we need to start lateral to the levator scapula, or it's going to feel like you're going over an adhesion when it's really just going over a muscle. It's going in the opposite direction. So you're not going to be as close to the head as you were with the upper trapezius. Find your little spinous scapula, fall into that notch, anchor yourself in, get your weight in your back foot, working with their breath. Slowly shift your weight forward. Same thing as I rotate my heel, I turn my dantian to get to my vector. Just shift your weight to your front foot. This muscle usually is a lot more tighter. It almost feels like a trampoline. A lot of times as you go in, it wants to bounce you back out. It's a smaller muscle. It's going to take a smaller tool. Careful not to get the little hairs. And you're going to take this all the way out to the acromion, just like before. But we know now that this muscle goes underneath the acromion, so we're going to end this stroke with a compression. So my first set of knuckles goes over the acromion first, and I want to get that last little edge of the supraspinatus. So I'm going to skedaddle up a little bit and get that top of that knuckle into that last little corner. And then once I hit the acromion, I'm going to change tools and I'm going to come into a thumb. And I'm going to go back into the acromion, but this time when I hit the acromion, I'm going to turn it into a compression. So I'm going to back up slightly, shift the weight down past the acromion, and then I usually look at my vector's going to go towards the greater tubercle, so I usually look at the elbow to see if I get movement. Here we go. Slight movement with my compression. And I'm still anchored because I'm close to the body. Supported thumbs. And then you hold for 30 seconds at least, or till you feel softening and resistance, and softening and less resistance of the fascia. And then slowly come out. There's our supraspinatus. Okay, number 5, levator scapula. I don't remember, I'm pretty sure I showed you guys levator scapula. I don't remember it being printed on the procedures. So I'll just show you again. If it's the first time, you can add it. You can put it anywhere you like. Sometimes people do it within the neck. So levator scapula, its origin comes all the way up here to, I think it's C1 through C4 of the transverse process, and then it goes to the superior angle of scapula. So the meat of the muscle, it really is from the top of the shoulder down to the scapula. But I also like to come up to the origin. And remember, yes, we did do this because we called it our doinking day. We're going to find, if you find the mastoid process and then just come a little inferior to the mastoid process, that takes you pretty lateral enough to feel this the transverse process of the cervical vertebrae. And then you're going to put your finger on one side and then you're going to push the vertebrae into your finger on the other side. Just to kind of loosen up the grip of the origin of the levator scapula. This is a nice way to kind of warm up the muscle, give it a little bit of a jiggle. And I just bring myself down each transverse process the best I can. I can kind of feel the bone up against my other finger. Is that uncomfortable, Elijah? Not uncomfortable. It looks kind of funky, but it's not uncomfortable. So my intention here is to make space between the cervical vertebrae and the scapula. Now I'm trying to open it up this way. Before, we'd made space between the cervical vertebrae and the scapula, but we're opening it this way. Now we're opening it this way. So I'm going to work myself down, and I can either use supported thumbs or I can use, let's use supported thumbs. So coming up from the base of the neck at a diagonal angle, almost kind of like a rhomboid angle, just up higher. I'm supported, and I'm going to use supported thumbs, and I'm just going to stroke down the muscle until I hit the superior angle of the scapula. Make sure your dantian is facing the direction in which you're working. Oh, I met a little space of resistance. So the stroke, I'm going to change to a compression. I'm going to hold that spot with my thumb, and I'm just going to change into a compression, very similar to our upper trapezius compression, but now my angle's at a diagonal because I'm working levator. Get my pressure, and then I'm going to get my vector. Sometimes I use the other side of the table as a little bit of a hold for myself. Relax wrist, relax shoulders, and then slowly come on out. And then I can continue my stroke. So that's levator. I'm just going to continue it on out, and then we're going to move into the rhomboids, procedure number 6. Most of us know the rhomboids from our cert class. You usually get the rhomboids done once and you remember it forever. Look at all the little releases we're getting all over when I'm just working levator still. Love it. Rhomboids, C7 to T5 of the spinous process to the vertebral board of the scapula. So now we just go from bone to bone. We're going to explore this muscle, take our time walking down the path, and anything that we find along the path that doesn't belong, little stones, what we call it adhesion, we're going to do something about it. Dantian is facing in the diagonal direction because my stroke is coming right off the vertebrae, sinking down, shifting the weight to the back foot, supported thumbs, and just working out to the scapula. So here our intention is to make space between the thoracic vertebrae and the scapula. Even though rhomboids begin at C7, the cervical vertebrae is usually just considered the neck, and we're really just trying to push the scapula away from the thoracic vertebrae, even though we are making a little space from the cervical. And if you see all those little, I don't know if you can see all the little, I guess I can call them muscle spasms. I look at those as releases. This is the body's way of speaking to me and letting me know we're doing something good and it's responding. So I like those. It's reassuring to me. And if we find an adhesion, we can stop there and just sit into, I think of it like a little anthill. I can either smush the anthill from the top, or I can just slowly glide over it over and over and again to bring it down a little bit more each time. Pressure okay, baby? And then we would continue this stroke the whole length of the rhomboids. At the end, we could do a little compression to go underneath the scapula where the rhomboids grab onto that axillary border and loosen its grip. And we know how to do compression. So we would continue the stroke of the rhomboids all the way down. Okay, next, lower trapezius. Stroke or compress the lateral edge of the lower trapezius from the root of the spine of the scapula to the 12th lumbar vertebrae. Sometimes, let me see if it shows on Elijah. Sometimes when I'm doing one of my last strokes of my rhomboids, my hand's shaking. When I do my last stroke of the rhomboid, sometimes that trapezius exposes itself. I don't know if you guys can see those little flitters that are happening in his back. Let's see if we can get his trapezius, the lower half of it, to expose itself. I'm going to follow up the edge in a second. Let's see if it'll pop. There we go. There's his trapezius. There's that edge of the trapezius. So I'm just going to come up near the spine, the root of the spine of the scapula, or where you see that edge of the trapezius, and we're just going to stroke down that edge. This trapezius, we know, is the most superficial muscle of the superior back. It's not very thick as we get down to the bottom. It's really thick up top, but as we get down to the bottom, it's not very, it gets a lot thinner. So it's very easy for me to sink past the trapezius into the underlining muscles underneath it just because of the depth of my pressure. And that's okay. If the fascia allows you to do that, go ahead and let it do that. So there's our lower trapezius stroke. Number 8, the multi-directional sculpting. What I like about this stroke is that it really allows you to become more confident in your work because you really have to start working with your intuition. Because remember, down here in this area, we have a bunch of layering of muscles. So we just saw that we have the trapezius, the lower part of the trapezius going this way. We have the rhomboids going this way. And then underneath all of it, we have the erector spinae going this way. So when you're working on this muscle, whatever muscle you are working on, if I'm going back to working the trapezius, if I'm going back to working on the rhomboids, and I feel an adhesion, and the adhesion feels like it's going this way, then all I have to do is switch my direction because now I believe that that adhesion is in the erector spinae. So we're just trying to get confident in the directions in which our muscles lie, and then move our body mechanics according to the muscle that we believe that we are working on, that adhesion is in. So our multi-directional sculpting. Either rhomboids, erector spinae, trapezius. So the intention of this is going to vary depending on the muscle that we are working. All right, so now we're moving on to the Teres muscles. This is our opportunity to be able to work this lateral border of the scapula that we don't get to do in a whole lot of other classes, especially in Circ, I know for sure. So we're going to work Teres major and Teres minor, and Teres major and Teres minor both they originate on the axillary border of the scapula. Teres major goes to the bottom 1/4, Teres minor goes to the upper 2/3. Teres minor is part of the rotator cuff muscle that comes around to insert onto the greater tubercle. Teres major goes underneath the arm to insert onto the bicipital groove. So their actions are going to be different. So this procedure is going to be broken down into kind of 4 steps. The first one, what we're trying to do with the first one is to release the scapula from the humerus. This is kind of Teres minor work, but even though Teres minor doesn't go all the way down to the bottom of the scapula, we're going to start there and work our whole lateral edge of the scapula, our whole axillary border of the scapula. So our procedure, series of compressions along the axillary border of the scapula to address the Teres minor and major, mostly the minor. So we want to find that axillary border, we want to find that lateral edge, feel the bone, and then just come right off of it. We don't want to push into the bone, we want to push just inferior to the bone. And our pressure is going to go straight in, working with breath. But then we have to have a vector. We're trying to release the scapula from the humerus, so I'm going to have a little vector going up towards the scapula. So I'm just going to push a little forward, stretch that muscle out. And I'm just going to do this whole thing, the same compressions all the way up the axillary border of the scapula. I can make small little circles to bring in a little bit more circulation, stir up that fascia, liquefy that ground substance, and then just follow that axillary border up. 1, 2 breaths, supported thumbs, and then a vector up towards that scapula. As you get higher and higher, the muscle becomes thicker. The teres minor does lateral rotation of the humerus. So sometimes to make sure that I'm on the muscle, I will ask my client if they can laterally rotate their humerus. And a lot of times what they'll do is they'll just do this. But laterally rotate the humerus has to happen from up here. So you can guide them. Could you move your arm back and forth like this for me? Give me 1 second. Let me relax for a second. Go ahead and relax it. Let me get in here a little bit. And can you do that again for me, please? Thank you. Go ahead and relax. So when he does that, I can feel the muscle contract underneath my fingers, making me feel a little bit more confident about where I'm compressing. And now I know I'm in the muscle because I can feel that muscle beneath my fingers. So don't be afraid to engage with your client. This helps them learn their body as well as get you more confident to do proper work. So, again, that lateral axillary border of the scapula goes a lot higher than we think. So if we're following the bones like we should, we're not going to stop right at the armpit. The muscle goes up even higher, and this is where it gets really good. This is where people are like, oh my goodness, I didn't even know I was sore there. And this will take us right into the second part of the teres minor procedure. Let me hold this compression, last compression as I read the second procedure. So finishing the procedure out for teres minor, we're going to get underneath the deltoid and vector towards his greater tubercle of the humerus, which is up here on the anterior side. So we have to get underneath the deltoid. This is one that you want to get your actions for, your lateral rotation. So would you mind moving your arm back and forth for me? Thank you. And it kind of feels like a V, like a little bit of a U. Go ahead and relax. So you're going to get up into, you're going to do a compression into the muscle and then drag it towards the insertion. So this one I usually stand up for. So I can use a double thumb. You can't, I know it's hard to see my thumb, but you got to just feel the scapula here underneath the deltoid and drag it towards and compress into with that vector towards that greater tubercle of the humerus. How's that feel okay? Is that pressure all right? And I think it's okay to make small little circles. I'm not digging, I'm just holding and I'm making small little circles, just bringing in oxygen and kind of exploring my area a little bit. Within that circle, is there a little bit of spot that I just kind of want to lean into a little bit more into that fascia right there. So how's that? So that is the end of our teres minor. So we're going to go back to teres major. Teres major is a little bit like a mini latissimus dorsi. So I have to get underneath the latissimus dorsi. So teres major is procedure number 10. Series of compressions deep to the latissimus dorsi to address the teres major. We're also going to be getting a little bit of subscapularis, warming that up for when we flip him over. And we're going to work along the axillary border along the scapula. So, going back to just where I almost was when I was on teres minor, remember we found that axillary border and we just went inferior to it? Do the same thing, but this time I have to get underneath latissimus dorsi. Latissimus dorsi is that whole back webbing of the armpit, and teres major is underneath that. So just go a little bit deeper, but still having that scapula just above. And now I'm going to have my vector going in, but my intention now is to make space between the scapula and the rib, so I'm going to lift up instead of towards the humerus. So it looks like so. Working with his breath, supported thumbs. Latissimus dorsi as well as teres major both do medial rotation. So as I move up higher, it'll feel more meaty to me, more musculature, and I'll have them do the movement of medial rotation so I know I'm on the muscle. Oh, there we go. So underneath latissimus dorsi, shift the weight in. Would you mind moving your arm back and forth for me? And they don't usually know medial or lateral rotation, but medial rotation is towards the table, so I just have him move back and forth. And as he moves it towards the table, I can feel that muscle contract underneath my thumb, so I know I'm on it. So I can pull that scapula into my thumb, shift my weight straight in towards the rib cage. And then for my vector, I can lift up. You can see that scapula just rise up. There, I'll move my fingers so you can see that scapula rise up. And again, I can make small little circles if I like. And I'm just like before, I'm just gonna work my way up the whole entire axillary border of the scapula to the very, very tip top. And if I follow the bone, I will be able to take it all the way to the tip top. So now it's getting a little thicker. The muscles are getting a little bit more meaty. Go ahead and rotate your arm back and forth for me again. This way. Thank you. Go ahead and relax. So now I know where I'm at, so I can start with my pressure. And then once I find a little pocket for my thumb, I get my vector. And again, I'm just going to follow this all the way up to the top. And then once I get to the top, the second part of this procedure is to, where's my second person? I'm going to release the insertion of the two muscles with the compression under the deltoid, vectoring towards the bicipital groove. So it's very similar to my second procedure, the Teres minor, but this time, instead of going to the greater tubercle, I'm going to go to the greater tubercle. I'm going to go to the bicipital groove. So get underneath it, get arm rotation for help with location. Thank you. And then vector towards that bicipital groove. And again, you can make small little circles if you like. So this intention is to make space between the scapula and the humerus, because now my vector is going towards the humerus instead of up into the scapula. And then slowly come on out. So we should have a little bit more movement of the scapula because we've loosened up the grip of the muscles hanging onto it in all different directions. And then at this point, we will flip them over and we will do anterior work on the subscapularis, pectoralis major, and pectoralis minor. All right, so subscapularis, the procedure, number 11. Anterior side of the body, we're gonna follow the ribs behind the anterior side of the scapula to compress into the subscapularis. So, what those words mean. No matter who we're working on, we want to support them above the elbow because then that's going to make them feel supported and they're not going to help us and hold up the arm for us. So hold above the elbow, and I like to just hold them into my side. And we want to put our fingers up against the rib cage. And we're just going to slide up. We're going to go up against the rib cage. We have to get to the anterior side of the scapula. So we're going to go up against the rib cage and slide past the rib cage and press down into the anterior side of the scapula. And if they're not giving me any body weight, then that means they're going to be nice and relaxed to allow me to get into that armpit area. So, in a bow stance, my fingers are up against the scapula. I'm going to follow my fingers are up against the rib cage. I'm going to follow the rib cage back to get into the scapula, and I'm just going to shift my weight forward. This, we want to take our time going into. It's a very vulnerable area. And not a lot of people have had fingers in their armpits before. So, be nice. Work your way in. What number are we at? Elijah has the pressure. So, I can just shift my weight a little bit more forward. My fingers are my working area to find the spot. It's like I've mentioned this, I'm kind of going into the cave or in between two clamshells. I'm trying to push the scapula away from the ribs, which are my two shells, and I'm looking in the meat, and I'm looking for the pearls. And those pearls are those adhesions. So I'm making small little circles. I can add pressure by shifting my weight into my front foot Or I can add pressure by pulling their arm towards me, which is going to pull their scapula into my fingers. Did the pressure go up? That was a if you didn't hear it. So then I'm going to slowly come out, and just above my fingers I found a little pearl, so I'm going to come out and go up a little higher. Same procedure, up against the rib cage, slide under, come down. So you can support here, which is what I usually like to do, or you can support at the wrist and you can pull the hand, pull the arm towards you, which is going to pull the scapula into your fingers. But I feel more secure myself this way, especially when I'm working on bigger arms. So that's one way to do it. The other way that we did it, slowly come on out, is leaving their arm down. Lifting up their shoulder and sliding my hand not around the humerus, but between the humerus and the scapula, for my fingers to be on the medial border of the scapula, and I'm going to slide the scapula out and then bring my fingers in. So this was our second option that we showed, whichever works best for you. Make sure the shoulders are relaxed as much as they can be, and again, we're going into an armpit. So be gentle, go slow. Let that muscle invite you in, don't be rude. And with this procedure, holding my arms this way, I can only get pressure by shifting my weight into my front foot. Make sure your front foot isn't past your work. If my front foot is past my work, I'm shifting my weight past my work. So make sure you're back far enough that your front foot is right about where your work's at, so you can shift your weight into your work. And again, my fingertips, the pads of my fingers, the fingerprint part of my fingers, that's my working surface. And I'm just making small little circles, looking for those pearls inside that oyster, or a clam, not an oyster. You can tell I don't have very many pearls. All right, we'll slowly come out. That's subscapularis. We're trying to move the scapula away from the rib cage. Moving on to the second to last procedure, pectoralis major. We're going to stroke or compress this from the sternal ribs 1 through 6, medial clavicle to the bicipital groove of the humerus. So our humerus attachments, we have the greater tubercle, which is the more anterior lateral knob. We have the lesser tubercle, which is the little knob medial, and the bicipital groove is the little space in between. We've kind of just talked to this about two little mountains and the valley in between. Lesser tubercle, bicipital groove, greater tubercle. The pectoralis minor all grabs here onto the bicipital groove. So starting at the medial clavicle and the rib cage and the ribs, which is its origin, we can just start warming this up. Remember, we are going back to our superficial sculpting. We can just slowly warm up. I'm not going too deep. I'm just kind of warming up the clay so I can make it more moldable, the way that I like the muscle to be. You imagine the muscle, looking at the pictures of the directions in which the fibers run, and then you just sculpt that muscle according to your vision. But to sculpt the muscle, you have to warm up the fascia. So we'll just warm it up a little bit. I can do some skin rolling if I wanted to. And then we're going to stroke out. So I usually start with fingers right at the sternoclavicular joint where the sternum and the clavicle come together. In a bow stance, I'm kind of straddling the side of the table. I like to work with my further arm away so my other arm doesn't hit his face. And I like to work across the top of the table, so I'm up high enough where I can shift my weight across the table and not into the table, because that kind of limits my movement. So as soon as I can drop into my palm, I'll drop into my palm, and I will just stroke out. If this was a female, I could do the same stroke. We can do the same stroke. We just can't go as far down if she chooses to be draped. And the same when we did our procedure earlier when we went to the scapula. I can just follow my palm all the way out, or I can kind of anchor my fingers and then pull my palm towards my fingers, whichever works best for you. And we're just gonna open up that muscle. And my intention here is really to make space. Most people say we're trying to make space between the sternum and the humerus, and we are, but we know that the humeral movement is only possible with scapular movement. So I want to think bigger, that I'm actually making space between the sternum all the way around the back into the scapula, so the scapula can move further away from the sternum. And then the fibers of this muscle, they kind of come down, they go across, and they come up. So I can also come down, even if he was a female, I can still have him draped. Yes, we will still have some breast tissue if this was female, but women have pectoralis majors and minors underneath the breast tissue. We just have to go through that extra tissue to get to the muscle. But a confident massage therapist is a good massage therapist, and you want to be well skilled in being able to work your way around the body. If you're comfortable and confident, they'll be comfortable and confident. So we can continue to work this muscle. And then all of this muscle, all these different layers of fibers, all gather right here to go into the bicipital groove. So I like to end my stroke with a compression. So where all these gathered fibers are, I like to use my forearm, not my elbow, my forearm, and get into this muscle. So I usually just make sure the arm's supported on the table. And I'm going to kind of lean into the muscle, pull it back towards me, and then compress it down towards the table to get a hold of the muscle, stretch that fascia, and then hold it down with the compression. So find your spot. You don't have to come in ready to work. Figure out where you need to work. Get a hold of that muscle. Work with your breath. Bring it towards you. And then shift your weight down and compress that muscle, and just add a little bit of pressure into the gathering of all those fibers. Pressure okay? That was good. And then sometimes you can feel little quivers, little twitching. This is all good. Sometimes you just feel a softening of the fibers. Use your own intention about how long to stay within a compression. Again, we are the guests in somebody's body, so we want to be a polite guest. We don't want to overstay our welcome, but we don't want to just be there long enough where we just started getting comfortable, the body started getting comfortable with us, and then we leave. So be in tune with what you feel. Use your best instinct, at least about 30 seconds, to make a complete change with the fascia before you leave. And then when you leave, you don't leave abruptly, you leave nice and slow. There's our pectoralis major. Last procedure of our pectoral girdle is pectoralis minor, number 12. So, stroke, compress from the sternum. Nope, that's pectoralis major. Sorry, number 13, pectoralis minor. From the side of the body, start compressions deep to the pectoralis major. Follow the ribs until the contact is made under the pec minor, and bow and lift the pec minor off of the ribs. So remember that coracoid process that was part of our scapula we talked about earlier. The coracoid process is the scapula that sticks out anterior on the body, so it's just a little bit inferior and lateral to the clavicle. Inferior to the lateral clavicle. If you push straight down, it kind of feels like a little bit of a marble. And the pec minor goes down to the ribs. So I come to the side of the body, get myself. If you're on a hard surface and your knees aren't used to it, don't be afraid to get a little padding for your knees. And I'm going to use my thumbs to push into near the rib cage, and I'm going to kind of come up. I'm going to get a hold of the medial side of pec minor and pull them into my thumbs, and then bow and lift up pectoralis minor. So, supported thumbs, always supported thumbs. As I shift my weight back, I pull the muscle into my thumbs, I shift my weight into the ribs, and I lift up. This muscle does depression of the scapula, which means slide the scapula down. So you can ask your client, will you slide your shoulder blades down on the table for me? Thank you. Go ahead and relax. And that will contract the muscle for you, and then you can tell when you're in the right spot. Why I'm lifting it up, underneath this muscle is part of the brachial plexus, which is that network of nerves that innervate the arm. So sometimes when people have issues with their arm, it's compression of those nerves from this muscle, kind of like the piriformis on the sciatic nerve. So lifting this muscle up is going to help give those nerves space. And I'm just slowly working down that pec minor. You can kind of see, it's kind of like right about here. That's the pec minor in the direction that it runs. So I'm lifting the lateral side of it, getting underneath it, and lifting it up. Kind of started in the middle and I worked my way down. Doesn't really matter where you start, but I didn't get this top edge. So I'm going to move myself over just to get that top edge of it where it gets onto that coracoid process. And pull it towards me. You can see me lifting it up. Supported thumbs in a small circle. And that could, sometimes that's all I do for the pec minor. You can also do compressions or strokes. So coming, if I want to do compression or stroke, I would use, again, not my elbow, but my forearm. And I'm going to sink down into the muscle just inferior to that coracoid process for my pressure. And then I want to vector, because my intention is to make space between the scapula and the ribs. So it's kind of like a backpack strap. I want to open this up. And I can do a series of compressions if I like. Make sure that back knee's bent. And I can just do compressions all the way down the muscle. Sink, vector, sink, vector. And then I can also do a stroke. You can start with a stroke, but sometimes strokes are difficult, and a series of compressions can make a stroke easier. You just have to be careful that if you're working with females, males too, we don't touch nipple. So this one's a little bit harder, where I lie my fingers. I'm just aware of where my fingers are. Doesn't stop me from doing the work, just be aware of where the fingers are. So I can feel him releasing underneath my stroke. And then coming on up. And then that is the end of all of the stuff that we've done so far on the pectoral girdle that we left off in March. So I hope that was a good review, and if you have any questions, let us know.